Okay, thank you for confirmation. So we can continue with some previous year topics followed by some previous year questions of anatomy. I hope everyone has received the file, the unannotated one, so you can just make your notes simultaneously. Okay, so we can start the session. Now, one of the important topic which is very frequently asked is layers of scalp. And I think most of you must be knowing that in a scalp there are 5 layers. There are 5 layers and the mnemonic is scalp itself. So SCALP, scalp. Now what is S? S is the outermost, that is skin. Then C is the connective tissue. A is aponeurosis. Then L is loose areolar tissue and P stands for pericranium. So this is pericranium. Clear? So these are the 5 layers of the scalp: skin, connective tissue, aponeurosis, loose areolar tissue, and finally pericranium. Now out of these 5 layers, you have to remember 3 layers importantly. So one is the connective tissue, second is aponeurosis, and the third one is the loose areolar tissue. So these are the 3 layers which you should remember, because most of the time the question is framed on these 3 layers. Now, as far as the aponeurosis is concerned, if there is any injury which involves this aponeurosis, so lacerations involving the aponeurosis, they tend to gape. Gape means they open up, and this is because on either side of the aponeurosis there are 2 muscles. One is occipitalis and another is frontalis, right? So suppose if this is the aponeurosis, on one side there is frontalis muscle, on the other side there is occipitalis muscle. So whenever there is any laceration like this, because of the pull of the 2 muscles, this is occipitalis, this is frontalis, so this wound will open up more. So it will become something like this. Clear? So just because of the pull of the muscles, the wound tend to gape. Gape means open up. So that is the importance of this particular layer, aponeurosis. Then loose areolar tissue is the dangerous area of scalp, right? So it is the dangerous area of the scalp. Why? Because the infection from outside the scalp can move inside the cranium through this loose areolar tissue, which contains emissary veins. Emissary veins are actually the connecting veins. So emissary veins are actually connecting veins. And what they are connecting? They are connecting the extracranial tissue with the intracranial venous sinuses. So what is happening? The infection which was outside the skull is now moving inside the skull and involving the venous channels. So that's why this loose areolar tissue is known as the dangerous area of the scalp. So the infection, it can move inside the cranial cavity, and the loose areolar tissue, it also gives a way of spreading of either the blood or the pus, and then it can move into the eyelids, producing the black eye, also known as the raccoon eyes. So the blood, it can trickle into the eyelids. So this trickling, it will produce a black eye or raccoon eyes. So this is again importance of the loose areolar tissue. Now what is the importance of this connective tissue? Now connective tissue, it impairs with the vasoconstriction, and therefore if there is any wound involving this area, it can bleed profusely, right? So these three are the important ones: the connective tissue layer, the aponeurosis layer, and the loose areolar tissue. So these are the three important ones which you should know, and they always fetch you some questions in the exam. Now let us take some practice questions. Now this question is asked in FMG. Now here the question was about like a patient who came to emergency department after sustaining a deep laceration over the scalp. Although the wound is small, but there is profuse bleeding. So the wound is small, but there is too much of blood loss. So now what is the anatomical reason for excessive bleeding from scalp wounds? So what is happening here? There is a deep laceration over scalp, and this is resulting in a small wound but excessive bleeding. Now how this is happening? The wound is small but it is bleeding profusely. Now it means the wound is in a layer where the vasoconstriction is not happening properly, and therefore although the wound is very small, it is bleeding profusely. And as I told you before, which layer of the scalp is that? That one is the dense connective tissue layer, which firmly anchors the vessels, preventing vasoconstriction. So this is the importance of the connective tissue layer of scalp. So here the wound may be small, but it will bleed excessively, right? So this is the clinical importance of the dense connective tissue layer of scalp. Now this is a FMG question. Then there is another question. A patient develops severe intracranial infection following an infected scalp wound. Now the infection has traveled, or infection has spread through which layer of the scalp? Now I think everyone can answer this. So there is a infected scalp wound, and now the infection has spread inside the skull. So intracranial infection. Intra means inside, cranial is skull cavity. So the infection which was outside the cranium has moved inside the cranium. Now this infection will be transmitted through which layer? Yes, can anyone answer? Now this is very easy, I think. Yes, can anyone would like to answer this about the dangerous layer of the scalp? Which one is the dangerous layer of the scalp? Yes, anyone? It's pretty easy. We have already discussed this. See, very good, bache. So this is the loose areolar tissue. Okay, so loose areolar tissue, and this is the dangerous layer of scalp because it contains connecting veins. So an infected scalp wound, the infection can be transmitted inside the cranial cavity, right? So loose areolar tissue. So we have discussed importance of two layers: dense connective tissue layer, which prevents vasoconstriction. So although the wound is small, but it will bleed profusely, And secondly, loose areolar tissue, which is the dangerous layer of scalp, transmitting an infection outside the cranium to inside the cranium. Now, this is one FMG question which is recently asked in June 2026. Now, here a patient suffers a transverse laceration, and this is involving the epicranial aponeurosis. On examination, the wound margins are widely separated. Which muscle is primarily responsible for this finding? So again, I think all of you can answer this. There is a transverse laceration in aponeurosis, and if there is a transverse laceration in aponeurosis, it can open up, or we call it gape. It will open up or gape, and this is because of which muscles? Yes, I am waiting for your answers. What can be the best answer here? Very good. So this is the two muscles, that is frontalis and the occipitalis, which are acting through the epicranial aponeurosis, and therefore they are pulling the tissue in their direction, and therefore the wound is opening up, right? So this is how you need to remember the three important layers of the scalp: dense connective tissue, aponeurosis, and the loose areolar tissue. So these are the questions which are usually framed from layers of scalp. Now moving forward to another very important topic, lateral wall of the nose. Now here you should know in which meatus which sinus are opening. So what are the openings and in which meatus? That is, you need to know. Now one of the important area is sphenoethmoidal recess, right? So this is sphenoethmoidal recess, and here you can get this word spheno. So spheno stands for which sinus? It is obviously for sphenoidal sinus, right? So sphenoethmoidal recess, the answer is quite easy to remember. Now, very good, sphenoid, yes. So this is also known as supreme meatus, right? So in some books you can also find this is also known as supreme meatus. So sphenoethmoidal recess is also known as supreme meatus, and in supreme meatus there is opening of sphenoid sinus. Very good. Now coming to superior meatus. Now here you can remember this PE. So this PE will help you in remembering P for posterior, E for ethmoidal, right? So in superior, what is opening? Posterior ethmoidal air cells. So superior meatus, posterior ethmoidal. Now plenty of sinus, they open into middle meatus. So plenty of sinus, they open into middle meatus. So now let us discuss the openings in middle meatus. The largest of all meatus is, yes, can anyone would like to answer? Anyone would like to answer about the openings present in middle meatus? What other sinus are there? Because we have discussed for sphenoid sinus, we have discussed posterior ethmoidal air cells. Yes, obviously, then anterior and middle are coming here, and then frontal sinus. And now which sinus is remaining? Maxillary. Very good. Arcagiri. Very good. So this is maxillary sinus. Clear? So this is about sinus openings. supreme meatus, superior meatus and middle meatus. In inferior meatus, there is no opening of any sinus. Now, can anyone tell me which duct opens into the inferior meatus? Which duct opens into the inferior meatus? Yes, I am waiting for your answers. Very good, Arkagiri, very good. So this is nasolacrimal duct. Nasolacrimal duct. Clear? Lacrimal is what? Lacrimal gland. So tears, and they are coming into the inferior meatus on the lateral wall of the nose. So this is a very important table. Many times it has been asked, and sometimes they give you image, or sometimes they will simply ask you. So please remember, inferior meatus, nasolacrimal duct; superior meatus, posterior ethmoidal air cells; supreme meatus or sphenoethmoidal recess, sphenoidal sinus, and all the remaining in middle meatus. Clear? Now let us take some questions based on this. A 34-year-old woman presents with chronic maxillary sinusitis. Endoscopic examination reveals obstruction of the structure through which the maxillary sinus normally drains. Now, what is the normal site of drainage of maxillary sinus? So we have already discussed what is the opening or the site of drainage of maxillary sinus. Yes, anyone would like to answer this? This is a FMG question and very easy. I think everyone can answer this. Yes, very good, Arkagri. So the moment you have any mention of the maxillary sinus, okay, so any mention of the maxillary sinus, this is in the middle meatus, right? So this is in the middle meatus, and that is through the hiatus semilunaris. Very good, bache, Arka and surgery made easy. Very good, right? So this is middle meatus, that is hiatus semilunaris. Now moving forward to next question. A patient undergoes endoscopic sinus surgery. The surgeon identifies a rounded elevation on the lateral wall of the nose, which is produced by the middle ethmoidal air cells. Now, what is this landmark? So, is a case of, now here there is a rounded elevation, and this is because of the middle ethmoidal air cells. So now here, see, one of the clue is given to you, middle ethmoidal air cells. So based on this, you can remember ethmoidal bulla. Okay, so this is ethmoidal bulla, right? So a rounded elevation on the lateral wall of the nose related to the hiatus semilunaris. This is bulla ethmoidalis, and this is produced by the middle ethmoidal air cells. So remember ethmoidal and ethmoidal, right? So that will help you. Okay, sure, no problem. Now this is a neat PG question and a slightly difficult, I would say, no problem. Sure. Now this is a FMG question. Now here the surgery which was done is dacryocystorhinostomy. Now during dacryocystorhinostomy, the surgeon identifies the opening of nasolacrimal duct on the lateral wall of the nasal cavity. Now, in which meatus does nasolacrimal duct opens normally? Now, I think it's a very basic question. So, Kartishri, Arkagiri, both of you are right. So, nasolacrimal duct opens into inferior meatus. Now, this is, yes, very good, bache, surgery made easy. So, this is very basic question, repeated many number of times. Please don't do any sort of mistake in these questions. So, lateral wall of nose is a very important topic. Every time you will have a question out of this, and this box will help you in solving such questions. So, please be perfect with this box. Okay, thank you. Moving forward to next important topic, and that is nerves related to parotid gland. Now, one of the nerve which is related to the parotid gland is the great auricular nerve, right? So, great auricular nerve, and now auricular word is related to ear, so it is also supplying the external ear or the pinna. So, great auricular nerve which is coming from C2, C3, and this is one nerve which is sacrificed during removal of the parotid gland, that is parotidectomy. So, the great auricular nerve is the most commonly sacrificed or injured nerve during removal of parotid gland. Now, what is the area which is supplied by great auricular nerve? It supplies the skin over the parotid gland, right? Then angle of the mandible, right? So, if the mandible is something like this area is known as the angle, right? So, where the mandible bends, so this is the angle. So, angle of the mandible is very important. And then, as the name includes great auricular nerve, so it supplies lower part of the auricle, or you can say pinna, and mastoid region. So, this all area is the territory of great auricular nerve which provides sensory innervation. Now, through the parotid gland, the facial nerve is passing through. So, the facial nerve travels through the parotid gland, divides into two, superficial and deep lobe, and after that the facial nerve is giving innervation to the facial muscles or the muscles of facial expression. So, if the facial movements are intact, it means facial nerve is okay. So, preservation of facial movements indicate that the facial nerve is intact, especially during surgery, right? Then I think if you take this word Frey syndrome, which happens after parotid surgery. Now, can anyone tell me which nerve is involved or injured in Frey syndrome? Any idea? Can anyone tell me which nerve is discussed whenever we are discussing Frey syndrome? And this nerve is carrying, very good beta, very good, Arkagri, very good surgery. But so this is auriculotemporal nerve. Okay, so this is auriculotemporal nerve. Now again, auricle means ear, temporal means the temporal region of the face. So this nerve is also supplying the external ear along with great auricular nerve, and this is also bringing the secretomotor fibers from the aortic ganglia to the parotid gland, and therefore it results in salivation from the parotid gland. So parotid gland salivation occurs because of auriculotemporal nerve, and sometimes whenever we are operating over the parotid region, and if there is injury to the auriculotemporal nerve, there is faulty regeneration of the fibers where the secretomotor fibers, they connect to the sympathetic fibers. So what happens whenever the patient is chewing, there is sweating over the region of parotid gland. So that is known as gustatory sweating. So we will take it some time later in maybe in surgery. So for the time being, please remember auriculotemporal nerve, and what is the function? It is bringing secretomotor fibers, means secretion of saliva from the parotid gland, and through which ganglion, aortic ganglion. Clear? So these are the nerves which are related to parotid gland. So one is great auricular nerve, second is facial nerve, third is auriculotemporal nerve. So if there is any question related to nerves around the parotid gland, you have to choose your answer from these three depending on the clinical presentation given in the question. Okay. So with this background, we can take the practice questions. Now, taking the first question, a 45-year-old man undergoes superficial parotidectomy for benign parotid tumor, most likely a pleomorphic adenoma, and during surgery, meticulous dissection is performed to preserve the nerve that divides the gland into superficial and deep lobes. So what is happening? Benign parotid tumor, right? So most likely a pleomorphic adenoma, and what surgery is being planned? Superficial parotidectomy, means removal of parotid gland. Now what is the surgical concern here? We have to preserve a nerve which is dividing the gland into superficial and deep lobes, right? So we have to look for that nerve which is dividing the gland into two components. Now, can anyone tell me which nerve is this? Yes, Arkagri, very good. This is the facial nerve. Okay, so this is facial nerve. So what you need to remember, this is the facial nerve, and remember one thing, parotid gland travels through the substance of facial nerve, travels through the substance of parotid gland, dividing into superficial and deep lobe, but does not give secretomotor fibers to parotid gland. So that's a very important thing which you should know about facial nerve. Facial nerve is supplying submandibular gland and sublingual gland, but not parotid. Although it is traveling through the parotid gland, but still it is not supplying the parotid. So that's the anatomical beauty, right? So whenever we are operating, we have to preserve the facial nerve as it is passing through the substance of parotid gland. Clear? So this is an FMG question, very basic one. Now the next question is actually a NEET PG question and slightly difficult, but let us see. A patient develops a reduced salivary secretion from the parotid gland and following injury to the aortic ganglion. Now, which cranial nerve provides preganglionic parasympathetic fibers that synapse in the aortic ganglion? So again, the question is about cranial nerve. So what is happening? Suppose if this is the aortic ganglion here, and suppose if this is the parotid gland, something like here, this is the parotid gland. So obviously there is a preganglionic and there is a postganglionic. So preganglionic, as the name suggests, before the ganglion, and postganglionic, as the name suggests, after the ganglion. So preganglionic is arcagri. Now see, trigeminal nerve is actually providing sensory supply to the face, okay, mainly, although it is mixed, all right. And here this is mainly provided by glossopharyngeal nerve, right. So this preganglionic is glossopharyngeal nerve, and postganglionic is obviously the auriculotemporal nerve. Clear? So please remember this much: postganglionic, auriculotemporal; preganglionic is glossopharyngeal nerve. Clear? So parotid gland is arcagri, very good bache. So this is glossopharyngeal nerve. Okay, so this is a slightly difficult question. This is from NEET PG, so no problem. So before ganglion, ninth nerve; after ganglion, auriculotemporal nerve. Okay, so please remember. Chalo. Next question. Now this is asked in the recently concluded FMG exam about surgical removal of parotid gland or a parotid mass. Now after this, what is happening? The patient is having numbness over the skin, over parotid, mastoid region, and classically angle of mandible. Now which nerve is injured during surgery? I would seek your answer. This is very basic question and we have already discussed in the main theory part, and I think all of you can solve this. Just recall what we have discussed. So obviously parotid mass is removed, so obviously we are giving an incision over the region of parotid gland, so that will injure a nerve which is supplying the skin over parotid gland. Clear? And classically this is also a clue: angle of mandible over the skin of parotid. This is great auricular nerve, right? So this is great auricular nerve, and I told you, whenever there is a question, very good arcagri bache, very good. Whenever there is a question about parotid gland, you have to think of only three nerves: great auricular nerve, facial nerve, or auriculotemporal nerve, right? So don't think of buccal nerve, lesser occipital nerve. These two you can straight away rule out. So if you have that basic knowledge, you will never be wrong in scoring questions. Okay, great. Now moving forward to one more important topic. Every year, every exam, it cannot be completed without keeping a question from this particular topic, that is intrinsic muscles of larynx. Now one of the muscle is lateral cricoarytenoid. Now for this you need to have a basic knowledge about the cartilages of the larynx, right? So crico is cricoid arytenoid. So lateral cricoarytenoid, it is adductor of vocal cord. Now adductor means brings the vocal cord closure, right? Brings them closure. So this is lateral cricoarytenoid. This is not very commonly asked, but you should know. But the one which is always asked is the posterior cricoarytenoid. So I think now you can understand. Crico is for cricoid, arytenoid, as the name suggests, this is arytenoid cartilage. So posterior cricoarytenoid. Now this is the only abductor. Now abductor means taking away. So it takes the vocal cord apart, and when it takes the vocal cord apart, it will open up the rima glottidis. So it is taking the vocal cords away, it is opening the rima glottidis, and it is opening up the airway passage, and therefore it is known as the safety muscle of larynx. So it is known as safety muscle of larynx, as it opens up the respiratory passage. Now if now this muscle is supplied by recurrent laryngeal nerve. It is supplied by recurrent laryngeal nerve. Now if both sides recurrent laryngeal nerve is gone, it means both side posterior cricoarytenoid muscle will be gone. So bilateral posterior cricoarytenoid will be gone, and therefore what will happen? Both the vocal cords will come to lie in the median plane. So there is both the vocal cords are in median plane, and what will happen? They will cause respiratory obstruction, and patient will come to us with inspiratory stridor. So as he is taking air in, there will be a whistling sound. So inspiratory stridor, and this is in cases of both recurrent laryngeal nerve palsy or both posterior cricoarytenoid muscle palsy. That's very important, and this is a potentially life threatening because the respiratory passage is blocked, so breathing cannot take place. Now cricothyroid, right? Again cricothyroid, again crico is for cricoid. So cricothyroid, and thyroid is obviously the thyroid cartilage. So this muscle, it is a tensor and elongator of the vocal cord, and this is needed for producing high pitch sounds, right? So tensor or elongator of the vocal cord, cricothyroid. Then thyroarytenoid, again from between thyroid cartilage and arytenoid cartilage. Now this is the relaxer. Okay, so it relaxes and shortens the vocal cord. So this thyroarytenoid is acting opposite to the cricothyroid. And then interarytenoid. Inter means between the two arytenoids. This is again adductor of arytenoid cartilages, right? So out of all these muscles, you have to remember mainly two. One is posterior cricoarytenoid, and the second one is cricothyroid. Posterior cricoarytenoid is abductor of vocal cord. Cricothyroid is tensor or elongator of vocal cord. Clear? So with this background knowledge, we can discuss few practice questions. Now this question is a FMG question. Now here patient undergoes thyroid surgery, but post-operatively there is severe inspiratory stridor, means the patient is breathing and as he is inhaling there is whistling sound, stridor. laryngoscopy reveals both vocal cords and they are fixed in the paramedian position. So there is bilateral paralysis of the abductor of vocal folds. Which intrinsic muscle is paralyzed? Now I think this is a very basic question and everyone should be able to answer this. Yes, I am waiting for your answers. So yes, very good, Arka agree. So there is severe inspiratory stridor, and this shows this hints that both posterior cricoarytenoid are paralyzed, clear, and therefore the vocal cords are in paramedian position, clear, both are in the midline. So this is posterior cricoarytenoid, and already the hint has been given to you, abductor of vocal cords, clear, very good, Arka. So please don't do any mistake in such a easy question. Now this is a question which was asked in the recently concluded FMG exam. A professional singer is unable to produce high pitched notes, and this is after injury to the external branch of the superior laryngeal nerve, as he was subjected to thyroidectomy, that is removal of the thyroid gland. Now which intrinsic muscle is denervated? Very good, Arkagri, very good. So there is, the patient has been operated, so there is surgical removal of thyroid gland. Now after that there is injury to the external branch of superior laryngeal nerve, and this is injured, and after this what has happened, the patient is unable to sing in high pitched notes, and if the patient is unable to produce high pitched note, it means vocal cords can't be tensed, and we know that which muscle is the tensor of vocal cord? It is cricothyroid. In fact, very good bache, cricothyroid. So in fact cricothyroid is the only muscle of the larynx which is supplied by external branch of superior laryngeal nerve. All other muscles are supplied by recurrent laryngeal nerve. So this is the only muscle, please remember, okay. So external branch of superior laryngeal nerve. So this is how you can solve this question, pretty easy, don't do any mistake. Now during phonation, now this is a PG question, NEET PG question. During phonation, the vocal folds are brought together to close the rima glottidis. Which intrinsic muscle is the principal adductor of the vocal folds? Again, if we are saying bringing together, right, vocal cords bringing together, it means which movement is happening? This is adduction, and the principal adductor, which muscle brings the vocal cord closure? Arka, very good bache. So this is lateral cricoarytenoid, okay. So this is lateral cricoarytenoid. So remember LCA. PCA is abductor, LCA is adductor. Very good bache, very good. So lateral cricoarytenoid, right? So you have to remember only three muscles. Number 1, posterior cricoarytenoid. Number 2, cricothyroid. And number 3, at times lateral cricoarytenoid, although it's not that commonly asked. Okay, so please remember this. Now, continuing the topic and taking the laryngeal nerves, we just discussed that external branch of superior laryngeal nerve is supplying cricothyroid, which is producing which is making the vocal cords tense or elongating them and producing the high pitched notes. So now superior laryngeal nerve, so if we write here superior laryngeal nerve, now superior laryngeal nerve has two branches. One is internal and the second one is external. Okay, and superior laryngeal nerve, it is coming from vagus. So superior laryngeal nerve is divided into two, internal and external. Now for external, we have already discussed that it is supplying which muscle. So external branch of superior laryngeal nerve, it supplies which muscle? Yes, anyone? And if that muscle is paralyzed, so high pitched sounds cannot be produced. Which muscle is supplied by external branch of superior laryngeal nerve? Yes, anyone? Which muscle is supplied? Very good, Arkagri. So this is cricothyroid. Clear? So this is cricothyroid. Okay, very good, bache, very good. So yes, both of you are correct. So this is cricothyroid. And the internal branch is actually sensory. Right? This one is motor. It is supplying muscle. But internal is sensory. It means it is giving sensory innervation. So now if suppose this is the larynx and this is say the level of vocal cords. So this area is all innervated by internal branch of superior laryngeal nerve. Is that clear? So internal branch of superior laryngeal nerve, it gives sensory innervation to the larynx above the level of vocal cords. And therefore, if there is any injury here, what will happen? There will be no sensations in the larynx above the level of vocal cord. So there is loss of sensation because it is sensory. And if there are no sensations, then cough reflex is hampered and that increases the chances of aspiration, right? Because protective cough reflex is absent, right? Because the sensations are not going, so one cannot perceive the presence of foreign body in the upper part of larynx above the level of vocal cord, right? Now the question is, which nerve is giving sensory innervation below the level of vocal cords? Which nerve is giving sensations below the level of vocal cords? Yes, anyone? Which nerve is giving sensation below the level of vocal cords? Yes, I am waiting for your answers. Please try. Let me see if you can answer that. Above the level of vocal cord, it is internal branch of superior laryngeal nerve, right? So above is internal branch of superior laryngeal nerve. Very good, Arkagiri, very good. So below is recurrent laryngeal nerve. Okay, very good, Arkagiri. So below the level of vocal cord, it is recurrent laryngeal nerve. right? Now, recurrent laryngeal nerve, it supplies all muscles of larynx, all intrinsic muscles of larynx, okay? So, all intrinsic muscles of larynx except there is only one muscle which is not supplied by recurrent laryngeal nerve. Yes, can anyone name that? It's very easy. We have already discussed that. Which muscle is an exception here? All muscles, all intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve except, yes, I am waiting for your answers. Very good, bache. Arkagree surgery made easy. Very good. So this is cricothyroid. And now you can tell me what is the nerve supply of cricothyroid? If cricothyroid is not supplied by recurrent laryngeal nerve, then what is the nerve supply of cricothyroid? Yes, nerve supply of cricothyroid. I think all of you must be knowing by now. We have already discussed it many times. Very good. So you have to write completely external branch, right, of superior laryngeal nerve. Yes, very good, Arka. Very good. Surgery made easy. Very good, bache. So you have to specifically write external branch because there is one internal branch also, but internal branch is not motor. So external branch of superior laryngeal nerve. Very good. Both of you are right, bache. So this is how you need to remember. So recurrent laryngeal nerve. Now, if there is unilateral paralysis of posterior cricoarytenoid, there will be hoarseness of voice, and yes, there will be impaired vocal cord movement, especially in case of posterior cricoarytenoid, there will be impaired abduction, then lateral cricoarytenoid impaired adduction. So all movements will go and patient will have hoarseness with impaired vocal cord movements. Clear? So this is in short about laryngeal nerves. Now let us discuss few questions. Okay, a 52-year-old woman undergoes removal of thyroid gland, thyroidectomy. Post-operatively, she complains of weak, breathy voice, right? So weak, breathy voice, but has no difficulty in high-pitched sounds. No difficulty in high-pitched sounds. Laryngoscopy shows there is paralysis of all intrinsic muscles on one side except cricothyroid. Now, which nerve was most likely injured? So, the patient is a case of surgical removal of thyroid gland, so thyroidectomy, and after that there is some nerve injury. Now, what is happening? Patient can produce high pitched sounds. So this is possible. It means the vocal cords can be tensed. And vocal cord tense means which muscle is okay? Cricothyroid is okay. And cricothyroid is supplied by external branch of superior laryngeal nerve. So this is also okay. So it means it is not paralyzed. Okay, because the patient can produce high pitched sound. So it means external branch of superior laryngeal nerve is okay. So this option is ruled out. Now there is paralysis of all muscles except cricothyroid. Now it is already written in the question statement. So all muscles paralyzed except cricothyroid. Now, what is the nerve supply of all remaining muscles except cricothyroid? I think all of you can answer this. So this is nothing except which nerve? Yes, Arkagri, surgery made easy. Very good, bachche. So this is recurrent laryngeal nerve. This is what we have discussed. All muscles, all intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Okay, very good. Now don't mix up. Now this is a neat PG question. A patient accidentally aspirates food without eliciting a cough reflex after surgery involving thyroid membrane. So which nerve is most likely involved or injured? So thyroid membrane area. Thyro is thyroid cartilage, hyoid bone. So in this, after this, so surgery on thyroid membrane, after this there is absent cough reflex, and if the cough reflex is absent, it means high chances of aspiration. So which nerve is paralyzed now? Arkagri, very good bachche. So this is the internal branch of superior laryngeal nerve, and we discussed before that it provides sensations to larynx above the area of vocal cord, right? So very easy to understand. Now this is a neat PG question, and yes, a few times it has been asked in FMG as well. Now again, during thyroidectomy, the surgeon is ligating superior thyroid artery. Obviously, if you are removing thyroid, you have to ligate the arteries which are supplying the thyroid, so that there is no bleeding post-operatively. Now he is trying to ligate the superior thyroid artery near the superior pole of the thyroid gland. Injury to which nerve is most likely if it is ligated too far from the gland? So suppose if the thyroid gland is something like this, so, and this is the superior thyroid artery like this, suppose. So obviously what we have to do, we have to ligate this artery so that whenever we are removing the thyroid gland, there is no bleeding. Now what is happening here, there is a nerve which is in close proximity. So I am drawing with blue, ideally the nerve should be drawn with yellow, right? So what the surgeon is doing mistake here, he is ligating too far. So what is happening? If he is ligating too far from the gland, there are chances that this nerve can be ligated along with the artery. So this is the superior thyroid artery. Now the question is that this is which nerve? Which nerve is this? Yes, anyone? Arkagri? Very good, bachche, very good. So this is the external branch of superior laryngeal nerve. Okay, so this is which nerve? External branch of superior laryngeal nerve. So therefore, whenever you have to ligate superior thyroid artery, ligate it here close to the gland, so that there is no possibility of injury to the nerve, right? So ligate superior thyroid artery close to the gland, close to the thyroid gland, and this will minimize any chance of injury to the external branch of superior laryngeal nerve. And I think most of you can answer, like if I ask you which muscle will get paralyzed, I think most of you can answer that it is cricothyroid, right? So please remember this beautiful concept. And yes, this is the diagram here. You can see this is the superior thyroid artery, right, going to the thyroid gland, and this one is the external branch of superior laryngeal nerve which is going towards the cricothyroid muscle. So it is somewhat like inverted V. So if you are trying it very far, you can ligate both the nerves and the artery in the same ligature, or you can injure the nerve as such. So better ligate the artery close to the gland so that the chance of injury to the external branch superior laryngeal nerve is minimized. So that's very important. Okay, so this we have already discussed here. Moving to the last topic for today, and that is facial nerve palsy. Now it has been asked many number of times, and almost I would say in every exam, whether it is FMG, NEET, PG, INICET, and the question is usually about upper motor neuron lesion and lower motor neuron lesion. Now if the question is upper motor neuron lesion, then the findings are on the other side. So what you will call that? Contralateral, opposite side, right? So contralateral means opposite side, and vice versa. In lower motor neuron, it will be ipsilateral. Ipsilateral means same side. So upper motor neuron, opposite side, lower motor neuron, same side. That's very important. Now there is one more important point. Here it is only lower half of the face and the forehead is spared. But in lower motor, the complete half, so the entire half of the face is paralyzed, involving the forehead also. So that's very important. So two important points: which side, same side, opposite side, and then how much area, complete one half or only the lower half sparing the forehead. So that's how you will differentiate. Now the forehead muscles, why they are spared? Because they receive bilateral corticobulbar innervation. So even if one side is gone, the other side will give them nerve supply, so they will keep on working. That's very important, right? So bilateral corticobulbar innervation. Then hyperacusis. Hyperacusis means intolerance to loud sounds. Loss of taste sensation from the anterior two-thirds of the tongue through the chorda tympani, I think most of you must be knowing, and reduced lacrimation, involvement of lacrimal gland. This all suggests that there is a lower motor neuron type of facial nerve lesion proximal to the respective branches, like nerve to stapedius or the chorda tympani nerve. If there is a lesion before that, obviously these findings will come. So this is how at least you should remember the upper motor neuron and the lower motor neuron. Now this we will discuss with the help of our table, and please be perfect with this table, and you will never do any mistake in this kind of question. Now if it is a upper motor neuron type of lesion, which side of the face will show weakness? Yes, I am waiting for your answers. Upper motor, which side? Same side, opposite side? Yes, I am waiting for your answers. Which side weakness? Same side or opposite side? I I think you can answer this. It's not that difficult. Upper motor neuron lesion. Which side weakness? Same side or opposite side? Yes. It's not that difficult. Upper motor neuron, facial nerve lesions. It will produce which side? Same side or opposite side? It is opposite side. Okay. So this is opposite side. Very good. Very good, bache. So this is opposite side. And for opposite, what word you will write? Contralateral. And just reverse it. In lower motor neuron, it will be ipsilateral, and ipsilateral means same side. Okay, so this is one important point. Then second, forehead involvement. In upper motor neuron, there will never be, so it is spared. But in lower motor neuron, it is involved. So there will be paralysis of the forehead as well. Very good, bache. So no forehead involvement in upper motor neuron. So yes, we can write no, and here you can write yes. Okay. Eye closure, this is preserved, and here it is absent. So the patient cannot close the eye properly. It will remain open. If you tell the patient to close the eye, on the affected side, if it is a lower motor neuron lesion, the eye will remain open. On the other side, it will close normally. Then hyperacusis or loss of taste sensation. This is from anterior 2/3 of the tongue, right? So this is from the anterior 2/3 of the tongue. Now all these findings are not present in upper motor. They are only present in lower motor if the lesion is proximal to the origin of respective nerves. Clear? So intolerance to loud sounds because they cannot be dampened, and loss of taste sensation from the anterior 2/3 of the tongue because of involvement of chordae tympani, they can be seen in lower motor neuron lesion if there is injury to the facial nerve before the origin of these respective branches. Then what are the causes of upper motor neuron? Stroke, that is cerebrovascular accidents, or some internal capsule lesion. And classically for lower motor neuron, remember one term, that is Bell's palsy. Remember Bell's palsy, and also facial nerve injury, that is again lower motor neuron. So based on this concept, now we can take some questions, and most of the questions are from NEET PG, so I presume they will be little difficult for you. But yes, if you try to apply basic knowledge, I think most of you can get somewhat closer to the answer, right? So moving forward to the questions, a patient undergoes superficial parodectomy. It means the superficial lobe of the parotid gland is removed for benign parotid tumor, yes, maybe pleomorphic adenoma. Now he is unable to close right eye, then unable to wrinkle his forehead, and unable to smile on the right side. Then taste sensation and lacrimation are preserved. What is the site of injury? So here what is happening? Let us write this. Taste sensation present. Then lacrimation present. But what is gone? Unable to close eye, right? Then unable to wrinkle forehead, and unable to smile, and all on which side? This is all present on right side. Now see, there is no mention of any sparing of forehead. So one thing is very clear, this is which type of lesion, upper motor neuron or lower motor neuron? Can you answer this? This is upper motor or lower motor? Very good, bache, very good. So this is involving complete right side of the face. So this is we can make a diagnosis. This is very good, Arkagri, very good, bache. So this is right sided because lower motor neuron facial nerve palsy. Okay, so I think yes, very good, bache, very good. So this is one thing which is clear now, because it is involving the entire face. So this is right sided lower motor neuron palsy. Now let us see the twist here. The twist is taste sensations are okay, lacrimation is okay. So now they are asking you about the site. So they are not asking you whether it is upper motor neuron or lower motor neuron. They are asking you the site. Now to answer this type of question, you have to understand the path of facial nerve. Okay, so you have to understand the path of facial nerve, then only you can say that okay, this is the most likely site of injury to facial nerve. And before we go on to that image, taste sensation is okay, lacrimation is okay. So it means the respective branches has already emerged, so they are spared. So it means there is injury to the facial nerve below the origin of the respective nerves which are providing taste sensation, that is the chorda tympani, or lacrimation, that is the okay. So let us come here. Now this is tongue. Okay, this is the lacrimal gland. So lacrimal gland, and this is the tongue here. So now what is happening? These two are working properly. Lacrimation is happening, taste sensation from the anterior two-third is also occurring. Now what it means, the anterior two-third taste sensation, this is by chorda tympani, right? So this is the chorda tympani nerve which is bringing the taste sensation from the anterior two-third. So it means the injury is somewhat distal to this area after the origin of chorda tympani. So the injury is distal, and distally you can see one opening here, and this opening is known as the stylomastoid foramen. This opening is stylomastoid foramen, and if you see one pointed structure, this is actually styloid process. Posteriorly there is mastoid process. So between the two is the stylomastoid foramen, and through this the facial nerve is coming out, then going through the substance of parotid gland, as we already discussed, dividing the parotid gland into superficial and deep lobe, and then dividing into the terminal 5 branches like this. So most likely the injury is somewhere here, because chorda tympani is already taken place, and then the greater patrocell nerve which is going till the lacrimal gland, this is also preserved. So these two are preserved. So it means the injury is somewhere here distal to the origin of chorda tympani. So taste sensation okay, it means which nerve is okay? Chorda tympani, this is intact, and this is the great patrocell nerve. So it means these two nerves are intact, and The only point which is distal to these two branches is the stylomastoid foramen. So the answer is facial nerve at the stylomastoid foramen. Yes, very good, Arkagiri. You are absolutely right. Okay. So greater petrosal nerve is, if it is involved, lacrimation will go. Chorda tympani involved, there will be no taste sensation from the anterior two-third of the tongue. So again, greater petrosal, lacrimation. Clear? So this is how you need to solve this question. So A, if you see in this image, this will give only complete paralysis of one half. If there is involvement somewhere here, only the taste sensation will go. And if there is involvement here, then there is paralysis of stapedius, so hyperacusis. And if there is paralysis somewhere here, there will be also loss of lacrimation. So depending on the level of injuries, you will be answering what actually we will see in the patient. Right. So if I just write it here, so what we can write, like site A, there is same site element facial nerve palsy. Clear? Now site B, which is just above the chorda tympani, so this plus loss of taste sensations from the anterior two-third of the tongue. So loss of taste from anterior two-third of tongue. Now if we go for C, C is here, this is C. So you will add hyperacusis. Patient will not be able to tolerate loud sounds. And if you go for D, you will, to all these three, you will add loss of lacrimation. So this is very commonly tested in exam. Now this is purely a NEET PG, or you can say even INICT level of question, very difficult, but yes, you need to remember just 2 points. A is stylomastoid, B is just above the chorda tympani, C is just above the origin of nerve to stapedius, and D is just above the origin of greater petrosal nerve, which is going till the lacrimal gland. Okay, so this is how you should remember. Now one more question from NEET PG based on the same concept. Now let us see. There is right-sided facial paralysis, but what we can see, there is hyperacusis, intolerance to loud sounds. There is loss of taste sensation from the anterior two-third of the tongue. It means chorda tympani gone. And there is reduced lacrimation. It means there is greater petrosal nerve which is also gone. So now what is the lesion? What is the location of this lesion? So hyperacusis, nerve to stapedius is paralyzed, then loss of taste sensation, then chorda tympani is gone, and reduced lacrimation. This is great petrosal nerve which is gone. So these are gone. So obviously the lesion has to be proximal to a landmark which is involving all these three. So Arka is saying B. No, if the lesion is between the origin of nerve to stapedius and chorda tympani, obviously it will involve only chorda tympani, and this will be normal, because suppose if this is the, I just show you a diagram, like suppose this is facial nerve. Now this is the nerve to stapedius. Lower down, this is say chorda tympani. So B, option B is telling you that nerve injury is somewhere here. So in that case, nerve to stapedius will be okay, and patient will not have hyperacusis, but patient is having hyperacusis. So it means the lesion is even proximal to this, and even proximal is greater petrosal nerve, right? So it means the lesion is somewhere here, then only it is involving all these three. So lesion is somewhere here. So very good, Arka, very good. I'm happy that you finally understood the concept. So this is proximal to an area, and therefore it is involving everything, and this area is actually the geniculate ganglion. Clear? So this area is the geniculate ganglion, and the lesion is somewhere here. The D we already discussed before. Okay, so this is a very beautiful concept, and if you remember it properly, so you can just put like geniculate ganglion here. So this is the geniculate ganglion. So the lesion is somewhere here. So proximal to geniculate ganglion. Clear? Chalo. Next question. Elderly hypertensive patient develops sudden weakness. So there is sudden weakness. Okay. So there is sudden weakness of the lower half of the left face after ischemic stroke. Although he is able to wrinkle his forehead and he can close the eye normally. Now, what is the best explanation for this finding? Classically, the patient is a known case of hypertension, now having ischemic stroke, and we discussed before, if there is a stroke, what kind of paralysis, facial nerve paralysis we can expect, whether it is upper motor or lower motor. If there is ischemic stroke usually results in which type of paralysis? Upper motor neuron paralysis or lower motor neuron paralysis, because this itself is giving you a basic hint. Now, after this, there is paralysis of lower half. Again, this is one more hint. Lower half, and then see wrinkling of forehead present, closing eye, this is also present. So everything is going in favor of upper motor neuron. Clear? So this is what? Upper motor neuron paralysis, right? So this diagnosis is clear to us. Clear? Now, what the question is asking you, like why the patient is able to wrinkle the forehead or close the eyes, although there is facial nerve upper motor neuron paralysis. And we discussed that why he can do that, because there is the forehead is getting bilateral corticobulbar innervation, right? So the upper facial nucleus, which is supplying the forehead and the eye muscles, is actually getting innervation from both sides. Therefore, even if one side is paralyzed, it doesn't make a difference, because the other side will control those muscles and the movement can take place. So for upper motor neuron lesion, this is bilateral corticobulbar. Now this is very important, corticobulbar innervation to the upper facial nucleus, and therefore despite facial nerve paralysis, patient can wrinkle the forehead, patient can close the eye. So this is in upper motor neuron. Okay, so please remember. Then a patient with Bell's palsy. Now I think the moment I write the word Bell's palsy, what is this? Upper motor neuron or lower motor neuron? Now what is Bell's palsy? Upper motor neuron or lower motor neuron? Yes, I am waiting for your answers. Bell's palsy is what? Upper motor neuron facial nerve palsy or lower motor neuron facial nerve palsy? Yes, anyone? Bell's palsy is upper motor neuron or lower motor neuron paralysis. Bell's palsy, this is classical lower motor neuron. Okay, so Bell's palsy is classical lower motor neuron paralysis. Now let us come to the question, which reflexes is most likely to be affected? Now Bell's palsy is lower motor neuron facial nerve palsy. Now out of these options, which is related to facial nerve? So out of these options, which is related to facial nerve? Any idea? Now remember, there is one reflex known as corneal reflex. Okay. So any idea whether it is A or B? Now I am just so let us discuss what is corneal reflex first. Corneal reflex is a protective reflex. Okay, so it is a protective reflex. Now how it is protects? The moment we touch the cornea with a wisp of cotton, what we will do? We'll touch the cornea with a wisp of cotton, and this will be followed by closure of eye or eyelids, you can say. So this is a protective reflex, and it just makes sure that there is no injury to the cornea. So if anything touches the cornea, similarly, simultaneously there is, you can say, blinking. Okay. So this is sensory component and this one is the motor component. Sensory is afferent and motor is efferent. Now all the sensations from the face, they are carried by trigeminal nerve. So the afferent limb, because this will go to the center and from the center will come the command. So afferent is by cranial nerve 5, trigeminal, especially the ophthalmic division 5-1, and efferent limb, this is actually by facial nerve. So this is cranial nerve 7, and what it will do, it will give command to the which muscle? Orbicularis oculi, and that will close or that will lead to blinking. So, and we know that facial nerve supplies all muscles of the facial expression. So all orbicularis oculi is also supplied by facial nerve, and that will result in blinking. So facial nerve is comprising of efferent limb of corneal reflex. So this is a one FMG question which has been asked a few sessions back. So in Bell's palsy, corneal reflex will be absent. The efferent limb especially will be affected, and therefore the corneal reflex is absent. So even if you touch the cornea with a wisp of cotton, there will be no blinking, and this is nothing except the fact that the patient with lower motor neuron facial nerve palsy cannot close the eyes, so eye remains open. So just a simple representation of that particular fact into a question format. Okay, very good, Arkagri. So with this we can end today's session, and I'm very sure you must have enjoyed the session. Very shortly I'll come up with few more PYTs, PYQs. Till then, keep on studying. God bless. Good night.